Hi, my name is Jason Chandler, and I'm doing a presentation on MPN updates today for this West Oncology Conference for APPs and nurses. So I'm sure you're all very interested and excited to hear about myeloproliferative neoplasms. This will include three different subtopics. So the entire category of MPNs would also include CML, but I did not include those for this talk. So I focused on polycythemia vera, essential thrombocythemia, and then myelofibrosis. So to the right, you'll see images of what the bone marrow biopsies look like for these three conditions. And so for polycythemia vera, we'll go through diagnosis, risk stratification, and some management. Essential thrombocythemia, a similar approach, looking at aspirin versus aspirin and hydrea. And then for myelofibrosis, there are some new drugs out, and spend some time on risk stratification as you decide who would be a candidate for stem cell transplant. So this will be just kind of one slide that I'll spend some time on because it breaks down the basics of how we should try to recognize patients that might need to be worked up for myeloproliferative neoplasms. So basically, someone comes in and they have polycythemia. For men, that would be a hemoglobin greater than 16.5, and women greater than 16. You're going to start thinking about polycythemia vera. There's other things that could cause that aren't necessarily from a mutation in the bone marrow or the stem cells, and that could be secondary polycythemia, like issues with renal artery stenosis, or perhaps like the patient is just not getting enough oxygen with obstructive sleep apnea or smoking. They have like a hunger to get more oxygen, so they make more blood. But it's really easy to rule out P. vera because 99% of the patients have a JAK2 mutation. So they have a mutation in one of their stem cells, and then it has a advantage or proliferative advantage. So 99% of these are going to have a JAK2, and or an exon 12 variant, the V617 or the exon 12. And when you're suspicious for it being primary versus secondary, oftentimes these patients will have symptoms like headaches or dizziness. Sometimes they talk about itching in the shower. They have usually like a ruddy complexion. So headaches, dizziness, and sometimes they have some early satiety, or they feel full really quickly, and maybe you're losing weight. So do the test, peripheral blood test for JAK2, and you can usually tell right away. Now, if someone has an elevated platelet count, you would think about essential thrombocythemia, or ET, and that's usually if it's greater than 450,000. And it's the same kind of process where a stem cell is mutated. In this situation, there are about 20% that have no mutation that we can identify, but most of the time there's JAK2, which is about 60%, CALR, CALR, and then just 3% MPL. So you usually just do a mutation panel for those if you're thinking about it. They can have many of the same symptoms of that lightheadedness. We think of these as like kind of vasomotor. There's something's going on with their blood vessels in these conditions. Sometimes burning in their hands and feet. And then, so both of these are ones of growth. You're making too many red blood cells. In ET, you're making too many platelets. And then in primary myelofibrosis, there is kind of like a drive, similar mutations, and you're trying to make too much, but it gets to the point where the bone marrow is scarred, or it's just gone too far. And then oftentimes the blood counts start dropping. So you have anemia, and then there's oftentimes an enlarged spleen. And sometimes a lot of the blasts will spill into the peripheral blood. So you do need to do a bone marrow biopsy when you're trying to diagnose these patients. So if you do get the mutation for JAK2, CALR, or MPL, the one on the left, you can see the pockets of fat. That's kind of a indication of the cellularity, how much stuff is in the bone marrow. So that would be ET. But you can have a patient with elevated platelet count that can be not yet full pulmonary, primary like myelofibrosis. And then so you can have like this pre-myelofibrotic condition. And so they look different. So you need to do the bone marrow to differentiate it, because the one in the middle, you need to be watching closely to make sure they're not going to progress to myelofibrosis. And the one on the left has pretty low risk. So need to get a bone marrow at diagnosis to put them in a different risk stratification. Okay, so for each of these, risk stratification is key and important to try to decide how you're going to address them. Because sometimes you do almost nothing for certain patients when you diagnose them. So for polycythemia vera, there's the link at the bottom for this calculator, and it's at MD Calc, so they have a lot of calculators at that website. But basically, you add up these points and you put them in a category. And to the right, you can see how those risks stratify. So if they've had a history of thrombosis, they say age 67, so around 65, but over age 67, you get points. If the white blood cell count is high, and then there is a specific mutation, so you would need to do the bone marrow to try to look for this SRSF2 mutation, and it gives you a lot of points. And so you can see how the overall survival on the right is so inferior for the high risk versus the medium or low risk. And you can look at those curves. The low risk is going out to 25 years for 50%. So these patients living a long time, practically dying of other things and not their P vera. So that calculator is available. This one is really interesting. So if you see at the bottom, it's Sanger, and this is the link if you're interested. So you can go to this website and enter lots of information. So you can have the age, what their hemoglobin platelets. If you do full next-gen sequencing, it'll actually allow you to put what mutations you know and don't know, the presence of splenomegaly. And so it takes all these clinical factors, genetic factors, blood counts, and it'll do this tool that will risk stratify that individual patient. And if you see the curves over to the right, so these would be patients like that just die of other things, or they die in myelofibrosis, or die of the myelofibrosis turn into AML, or all these different ways that they could that can happen to them in the next 20 years. And if you have different mutations and different panels, this can be radically different. But usually this risk you see really starts kicking in at about 15, 20 years. So if you have a really young patient, their risk of dying in 15 years is pretty high. And if you have like a 70-year-old, probably this is not going to affect their lifespan as much. So this is just for P vera, not even some of those other conditions. You can use this same tool for ET, P vera, and I think for primary myelofibrosis as well. But you put all the mutations in, just the ones you have. It's a very neat tool. It takes a little work, but it's interesting to kind of give a patient plan for the future. So if a patient has, we saw at not the second one, but the first one, where you can put them in different categories, low risk versus high risk. And that was things like age, their risk factors like previous clot, if they have the JAK2 mutation. In this situation, they definitely would have it. For P vera, it's different for ET. Low risk, you just want to give them an aspirin, which actually helps some of those vasomotor symptoms, and then keep their hematocrit less than 45 with just phlebotomy. And that was based on a study at the bottom, the reference, the CytoPV study in the New England Journal of Medicine. And basically, they looked at two different levels, trying to get the hematocrit to 48 versus 45. And the patients did better with less events like strokes and blood clots at 45 than they did 48. Now, in that situation, they don't recommend cytoreductive chemotherapy unless you're failing or not able to do this. But in higher risk patients, not only do they recommend doing the phlebotomy, but they also recommend chemotherapy to try to knock the counts down, like the hemoglobin, and keep the platelets and everything under control. So those are at higher risk patients. And you'll see that the different drugs recommended, hydroxyurea, and then also interferon. So Rho pegylated interferon is called Bezremi, and then alpha 2A pegylated interferon, Pegasus. These are kind of different treatments. So for one study that was the PROUD PV study, that was the one to the left. It was for the first 12 months. And then patients were allowed to continue in the continuation PV study. So basically, this was patients that were in that risk category that needed hydrea, so the higher risk ones. And so you could say they do hydrea or they do pegylated interferon. So to do the pegylated interferon, you do sub-Q injections. And the good thing about this is interferon. So basically you get it and you feel like kind of like you have the flu. Earlier versions of interferon, you'd have to give 3 times per week and had quite a bit of side effects, including depression, just that flu-like symptom of feeling fevers or chills or just tired all the time. And so when they reformulate it where you only have to give it every 2 weeks, those symptoms are definitely less, but they still exist. So this is probably the best tolerated of any of the interferons since it's only every 2 weeks. And at first we had trouble getting insurance approval for these when we wanted to use it, but it's gotten a little better, and it is now in the NCCN you saw before, kind of in the recommended. So they were looking at how much the spleen shrank, hematocrit at target, and some other factors like how often they needed phlebotomies. So this would be like a complete hematologic response. So they're saying first at 12 months, that was the first study, and then they continued it. So actually, in the first 12 months, if you see the curves, the control arm, the hydrea, actually did a little bit better for the first 12 months, but longer in the continuation, and now this is followed out to 6 years, the pegylated interferon definitely helped, did better. And so more of these patients had control of their spleen symptoms, and more of them had controlled hematocrits. And what's interesting is, so if you do just their blood, you can do an allelic burden, and we can order this for JAK2. So you can just do a blood test and see what percentage of the cells have JAK2 in them, 70%, 80%, and then treat with these drugs. And so after different time points, 20% of the patients on the interferon had less than 1%. So they would preferentially affect this stem cell and shut it down. Whereas with the interferon, it was a very small percentage, like 1.4. So the thought is that maybe these interferons can change the natural history of these diseases and not have those curves dropping off like we saw earlier that could maybe go to myelofibrosis, maybe. So they haven't been able to prove that yet, but that's the thought process if it hits the stem cell population preferentially. So that was in higher risk when you had to do hydrea. This is in the lower risk ones. So the lower risk patients, they also compared, if you're going to do phlebotomies, if you added on this interferon, would they do better? And basically, if you look at it, hematocrit control was 81% versus 58%. So by adding it, they had a much higher rate of keeping that hematocrit at the target. And then it also changed, like before, the JAK2 allelic burden, like what percentage of the cells had JAK2. And so this is and then also strength of spleen. Patients seemed to feel better. So they had to deal with the side effects of the interferon, but they seemed to feel better. So that was P-Vera, risk stratify them, manage them. ET is similar, that it's a stem cell disorder. You have risk of clots. So both of these myeloproliferative disorders, all of them, there's increased risk of clotting and strokes. But if your platelets get high enough, like greater than 1.5 million, you have this acquired von Willebrand deficiency. So the platelets kind of take up all the extra von Willebrand factor, and these patients are actually at increased risk of bleeding. So you can, the old stratification that I originally learned when I was in training was you had low and high risk. So basically, if you were less than 60 and no thrombosis, or greater than 60 and a history of thrombosis, that's the risk stratification. But this new IP set prognostic categorization has 3 factors. So JAK2 is a negative factor, having a previous thrombus, and then age greater than 60. So if you have no factors, you don't have to do anything really. You may not even need to give aspirin. If you're just JAK2 positive and you don't have clots and you're younger, you can do just an aspirin. There's a question of when you get over 60, do you need to really do the cytoreduction? But if you're high risk, they really recommend the aspirin and cytoreduction, or like medicines to bring the counts down. So if you're not in that high risk group, they actually did a study. And even when patients had platelets that were like 1 million, not even up to 1.5 million, they tried aspirin or aspirin plus hydrea, and there didn't really seem to be much difference between the two. So really, you don't have to start right if they're not high risk, if they don't have those high risk factors, high risk being the previous thrombosis greater than 60 and JAK2, it's not really clear how much hydrea is helping this patients that are 40 to 59. Unless their platelets get way high, like up to 1.5 million. So if a patient has ET and they're young with just JAK2 mutation, like you can get away with just aspirin and manage their risk factors. But if they are older with JAK2 or have these other high risk factors, you would consider cytoreductive treatment. The preferred agent is hydrea, but you can use pegylated interferon, although it's not FDA approved for ET. It's only FDA approved for P-Vera. So sometimes it's hard to get paid for, but oftentimes insurances will, in certain situations, pay for it, or there's an agrelide. So we did P-Vera, ET, and now myelofibrosis. So of these, the most important one for risk stratification is myelofibrosis, because you really want to put these people in different categories. So this is a really complicated one. You see all the factors that go into it. So you just get a point for each. And at the bottom, you see these high molecular risk mutations. So at the bottom, ASXL1, EZH2, SRSF2, IDH1 and 2, these are those high molecular risk mutations. So if you have one, or even worse, if you have 2 of them, that really ups your risk category. And you can see the very high risk, the red, how terrible those patients do, with nearly 100% of them dead at 5 years. So the low risk, you could actually watch, and this risk calculator is also at the bottom. There's a link to it there. So you saw all those points you put in, and you put people in different categories. So low risk, and they're asymptomatic, you can just watch them. If they're having symptoms, usually ruxolitinib or Jakafi is good. So they don't have to have a JAK2 mutation for it to work. Even though it's a JAK inhibitor, it's the JAK pathway it blocks. So if they can have CALR mutation, you can still use Jakafi or ruxolitinib. But you can also use pegylated interferon or hydrea. Now, the higher risk, you saw how those curves dropped. These patients just have a really high risk of dying. Transplant is not the easiest, allogeneic stem cell transplant for myelofibrosis. So they don't do great, but when they do so horribly with the disease, that's when you start thinking about transplant. So if they're eligible for transplant, you want to go ahead and get that started early. If they're ineligible, then you would put them on a drug. You've got ruxolitinib, and then there's another drug, fedratinib. But if patients' platelets are low, oftentimes, like we said, this myelofibrosis, the bone marrow is scarred. And so basically what's happening is the gas pedal has been pushed for so many years that it can just scar down, and there's no place to make blood there anymore. So your body starts shifting to the spleen to make blood or other places. And so you get more like bone pain issues. And so that spleen can get huge and the bone marrow just doesn't work and your platelets start dropping. And if you've ever given Jakafi to someone with low platelets, it drops them even lower. So you really can't use those drugs. So they just came out with a new drug called pacritinib, and it's for use in patients with platelets less than 50. So basically, if a patient just has anemia, it is difficult to manage those symptoms because the ESAs don't really work that great. There are things like thalidomide, and they don't work great either. Like these steroids, danazol, or transfusions. I mean, there's not a lot of great ways to manage anemia, but these are a few of them that you can try. Looking at ruxolitinib or Jakafi in myelofibrosis, you can see it was studied like the spleen volume and their symptom score, and they compared it to placebo and they compared it to the best available therapy, and they weren't that much different. So basically, Jakafi definitely works better than placebo, and it pretty much works better than other drugs. Now, this is really interesting. So if you've used Jakafi before, on the left is the spleen size change, and on the right, it's the total symptom score. And so at the lower dose, placebos to the far left, less than 10 milligrams, there's not much change in symptoms or spleen size. 10, you do pretty good, 15 better, 20 better. So the super low dose is not really doing much in these patients. So you have to get at least to 10 milligrams and you can get a better response going up, but then it's going to knock their blood counts down. So they did the PERSIST study, which was pacritinib. So this is in those patients with less than 100,000, but it'll actually work in those less than 50. And they tried different doses. So these are patients with myelofibrosis and low platelets. And this is a similar thing. So usually what they're measuring is their spleen volume change and their symptom change. So pacritinib, these patients are in a tough place, but this is an option for patients with low platelets that have myelofibrosis and you can't get them to transplant. So basically, sorry on this, the screen changed. So polycythemia vera, the second one should say essential thrombocythemia, and then myelofibrosis, mainly focusing on some of the newer agents such as Besremi, like pegylated interferon, and pacritinib versus fedratinib and Jakafi or ruxolitinib for patients with myelofibrosis, P-Vera, and then for ET, like which patients that should receive aspirin or cytoreductive therapy. All right. Thank you, guys.